Sometimes the biggest lessons in medicine don't come from massive studies, but from a single incredible case. Today, we're going to dive into one of those stories, a case that really pulls back the curtain on the invisible, high-stakes science of anesthesiology. So, just picture this. A baby's life is on the line, and an immediate C-section is the only option. Simple enough, right? But what if, for the mother, the very drugs that make surgery painless could actually trigger a fatal reaction? That's the razor's edge this medical team had to walk. All right, let's get into the details and meet the patient at the heart of this medical puzzle, where every single pre-existing condition just added another layer of complexity to a life-or-death situation. So our patient is a 28-year-old woman, 38 weeks pregnant with her first child. But she's also living with a muscle-wasting disease she was diagnosed with back when she was 20. It's already gotten to the point where it affects her walking and even her breathing when she sleeps. She actually needs some breathing support at home from time to time. Suddenly, the situation goes from manageable to critical. Monitors start blaring. Fetal tachycardia. The baby's heart is beating way, way too fast. There's no time to wait. The team has to perform an emergency C-section, and they have to do it right now. And this right here is where an already stressful situation gets incredibly complicated. For the anesthesiologist, this is anything but a routine C-section. The patient's underlying disease completely changes the game. See, the patient has a condition called limb-girdle muscular dystrophy, or LGMD. It's a genetic disorder that causes the muscles closest to the core of your body, think hips and shoulders, to get progressively weaker. But the effects, they go way deeper than just that. For an anesthesiologist, a patient with LGMD is like navigating a medical minefield. Her breathing muscles, already weak. Her heart, potentially compromised. And here's the biggest one. She has a dangerous sensitivity to some of the most common anesthesia drugs that could trigger a potentially fatal, whole-body muscle catastrophe. Let's put a number on that breathing risk. Her forced vital capacity, which is basically a measure of her lung power, was only at 60% of what you'd expect. To the medical team, that's a gigantic red flag. It tells them her ability to just breathe on her own under the stress of surgery is going to be seriously, seriously limited. So what do? You can't just follow the standard playbook. It's out the window. They had to build a custom plan from scratch, one that was tailored to this one patient and her very specific, very dangerous set of risks. They were basically staring at two very different paths. Path 1, general anesthesia, where she's put completely to sleep. The problem? That was incredibly risky. It could make her weak breathing muscles fail entirely, and even worse, trigger that catastrophic reaction we talked about called malignant hyperthermia. Path 2, regional anesthesia. This would just numb the lower half of her body, letting her stay awake, and crucially, avoiding all those big risks. Well, when you lay it out like that, the choice becomes pretty clear, doesn't it? It was all about eliminating risk. So the team chose spinal anesthesia, a type of regional block that would keep the mother awake, breathing on her own, and completely sidestep the biggest dangers her condition presented. Their preparation was just meticulous. They decided to use a real-time ultrasound to guide the needle, making it as precise as possible. They made a strict list of drugs they absolutely could not use. No depolarizing muscle relaxants, no volatile gases, which are known triggers. And as a final safety net, they had the antidote, dantrolene, on standby just in case the worst happened. This wasn't just a plan, it was a fortress of safety measures. All right, so the plan is locked in. The team heads into the operating room. Everything they've prepared for is about to be put to the test over the next 40 minutes. And the result of all that careful planning? Just a masterclass in medical efficiency. The entire C-section was done, start to finish, in only 40 minutes. The outcome for the baby couldn't have been better. A perfectly healthy newborn scoring an amazing 9 out of 10 on the Apgar scale. And for the mom, blood loss was totally manageable, just 600 milliliters. It's another sign that the procedure just went off without a single hitch. And here, this is really the proof of how precise this plan was. Her blood pressure and heart rate, what we call hemodynamic stability, was kept perfectly stable with just one single tiny dose of medication. This was total control, not crisis management. But wait, the story's not over. For a patient with LGMD, the danger doesn't just stop when the surgery ends. The recovery period is just as critical, and it needed an equally thoughtful, proactive game plan. The team stayed way ahead of the curve. They immediately put her on non-invasive breathing support, a BiPAP machine, just to give her respiratory muscles a break. For pain, they used a plan that avoided opioids, so there was no risk of slowing down her breathing. And they kept a close eye on her blood work, watching for any sign of muscle breakdown or high potassium, both known risks for LGMD patients after a major stress event like surgery. And the result of all that incredible foresight? Mom and baby were discharged together on day 5. Healthy, happy, and with 0 complications. I mean, what a perfect outcome to an absolute high-wire act of medical care. So why does this one story matter so much? Because it's more than just a great outcome. It's basically a masterclass in how to handle incredibly complex medical challenges, and the lessons here apply way beyond this single patient. When you boil it all down, this case really hammers home 3 core ideas. First, the incredible power of a multidisciplinary team. You had heart, lung, and anesthesia experts all collaborating. Second, using technology like ultrasound not just as a cool gadget, but to make a difficult procedure safer and more precise. And third, maybe most important, the idea of proactive management, solving problems before they even have a chance to start. And that kind of leaves us with one final thought, right? By meticulously navigating one rare, super complex case like this, these teams don't just save one life. They're actually building a roadmap. They're refining techniques and creating knowledge that ultimately helps make medicine safer for every single one of us.